Back again. Hopefully from this session you'll get a good understanding where airway obstruction may occur in the upper airway, and importantly understand the anatomy of the area so you can be confident doing cricothyroidotomy in the middle of the night in case there's nobody about and you've just got to go on and do it. Hopefully you never have to do that. If you've got that knowledge of anatomy, then you'll be pretty confident about doing it. So what I want to do is to review the anatomy of the airway. We want to be able to identify the cricothyroid membrane on yourselves and hopefully on one of your colleagues, particularly if there's some flatmates there. If they're an English student, don't worry, just pin them down and fill the neck. And I think about what's behind this cricothyroid membrane and what's below it, and then we'll talk about what is a cricothyroidotomy. I can't say it either. So without further ado, you get your pen and paper out and pause the video. So let's first off look at the anatomy of the upper airway from the side. We've got that part within the maxilla, the mandible, and the larynx. In a trauma situation, if we have trauma to the maxilla is forced backwards, this will close off the pharynx and the nasopharynx to the back. If we have trauma in the mandible and the mandible is unstable, the tongue can go backwards, particularly in the unconscious patient, and press against the pharynx and obstruct the airway at that time as well. In this situation, any straightforward procedure by pulling the maxilla forwards or pulling the mandible forwards and stabilising it can open the airway very straightforwardly. And a Goodell airway into the mouth, that's what it does, it brings the tongue forwards and puts your tube at the base of the tongue. If we're going to look at the larynx though, I think we're probably better doing that on the model with one of Charlie's elegant illustrations and some of the terminology. I'd like you to particularly notice that the cricoid cartilage is a complete ring. This is very important, this ring isn't damaged, so we can keep the structure and stability of the larynx. So let's have a look at that anatomy on this enlarged plastic model. In the front we've got the prominent thyroid cartilage. Below that we have the cricoid cartilage. And between the two we have the cricothyroid membrane. Above there we have the epiglottis. Let's have a look from inside the pharynx as we view for each patient. We can see the vocal cords attached to the arytenoid cartilages and the epiglottis protecting that during swallowing. In these fossae, the period from fossae, foreign bodies can get stuck at this level. If you have an enlarged epiglottis due to epiglottitis, you can see this would cause obstructions in the sputum here. It's important to note the level of the vocal cords. You notice there at the level of the mid part of the thyroid cartilage, way above the cricothyroid membrane, which is at this level here. Therefore, if we gain access to the airway from the cricothyroid membrane, we are going to be below any form of obstruction, and there's nothing behind it to injure at this level. One of the questions which we'll return to now. So, a cricothyroidotomy is essentially making a hole in the cricothyroid membrane, so you can gain access to the airway and the patient can breathe through it. You can place an endotracheal tube into the trachea through that hole or any form of tubing. This is your classic Bic Biro or penknife procedure done on an aeroplane. On the ward, you can do a needle cricothyroidotomy. You should all be confident now to feel the membrane with a white needle, ideally on a syringe if available. Push the white needle through the cricothyroid membrane, aspirating as you go. Once you're aspirating air, you know you're in the airway. Remove the syringe and you can deliver oxygen with a breathing mask over the end of the needle. You can also use jet insufflation by getting more oxygen into the airway. You can attach the oxygen tubing to the needle and just inflate for a few seconds and then take it off again. You can change it to a formal tube once you've got the equipment and help on hand, if you need to. Let's go back to the model. So a cricothyroidotomy is when we get emergency access to the airway through the cricothyroid membrane between the cricoid cartilages and the thyroid cartilage. This is relatively superficial, and as we say, can be done as an emergency, compared to a tracheostomy, where a formal incision is made in the trachea, having gone through the middle of the thyroid gland. So hopefully that's been useful. Let's just summarise by reviewing the questions and the answers. Where can you get air obstruction? In the trauma situation, anything from the maxilla pushed backwards can obstruct the airway. The tongue falling backwards can obstruct the airway. Fractured mandibles allow the whole lot to move backwards as well. In the larynx, the epiglottis being swollen, epiglottitis can obstruct it. And foreign bodies can get caught in the upper part of the larynx around the vocal cords and the piriform fossae. And very importantly, hopefully you can all comfortably identify your cricothyroid membrane between your thyroid cartilage and your cricoid, and you've done this on yourselves. Do it on each other in the flat, but also when you re-examine the patient's neck, just have a gentle feel so you can do it. So if you do have to do it at 2 o'clock in the morning, because the rest of your team's tied up in theatre or somewhere else, you know you can get something into it, either a needle with jet insufflation or maybe even a knife. Because you can be confident there's nothing behind it. You blow all the clockwork of the larynx and you're just going to go into the airway. There's no vessels. So you'll be confident what a cricothyroidotomy is. A bit scary if you have to do it, but now you've got the knowledge and the anatomy to be quietly confident you can save that person's life. Good luck.